Okay, I think we're set. Hey, good morning, Dr. Mel. Dr. Mel Pohl, how are you?
I'm great, Tim. How are you?
Doing fantastic. I can't complain. It's a beautiful day in Arizona. I got to work out. You know, we're through the summer. I know you're in Las Vegas. Are you still in Las Vegas right now?
Right at the moment, I'm in San Diego, but I spent a lot of time in Vegas, and this summer it's a hot summer.
It was a hot summer, like record-breaking summer, record-breaking heat.
Yeah.
Well, we are here. My name is Tim Westbrook. I'm your host of Sober. I'm so grateful to be here with Dr. Mel Pohl. Dr. Mel Pohl is an MD, DFASAM, which is a distinguished fellow of the
American Society of Addiction Medicine.
American Society of Addiction Medicine, which is a big deal. He's a family practitioner and is the medical officer of Las Vegas Recovery Center. Dr. Pohl was a major force in developing LVRC's chronic pain recovery program. He is certified by the American Board of Addiction Medicine, and he is a clinical assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Nevada School of Medicine. He's the author of A Day Without Pain and the Pain Antidote, Suffering from Chronic Pain, Avoid Addiction, Killers, and Reclaim Your Life. Dr. Pohl filmed a show for PBS on chronic pain aired around the country in 2016. So the topics today, in case you couldn't guess, is going to be around chronic pain and addiction recovery. And Dr. Pohl, thank you so much for being here. Well,
great to be here. It is.
Yeah. We were talking before the show. I've seen you speak multiple times, and I've seen you around, and you and I haven't ever really gotten the opportunity to get to know each other. So really excited to get to talk with you today and learn more about you, learn more about why you're passionate about the work that you do, and let's provide some education for some people, because there are lots of myths out there and lots of things that are not true. And the opioid epidemic is such a big deal right now, and so I'm really just excited to talk with you about that today. So let's start with you. Tell me a little bit about you and where you grew up, and just tell me kind of where you came from and what happened.
And what it's like now. My favorite topic.
Right.
So I was born in New York and went to college at University of Michigan, go Blue, and then I ended up at the University of Buffalo Medical School for 7 winters, and decided I had enough of winter, and ended up moving out to Las Vegas, the opposite, and the heat. And I've lived there for over 35 years, actually, in a variety of clinical medical settings. I'm a family doc, and I came out to be a family doc. And when I first moved there, I got a job opportunity working in a treatment center. 3 years later, I got sober. So I was the medical director of a treatment center, giving these great lectures on cocaine.
That makes sense.
Yeah. Not saying it proudly, but it's just the fact.
Hey, it is. That's your story, right?
Yeah, it is my story.
Let's back up for a minute. When did you start? Okay, so when did you start experimenting with drugs and alcohol? When did that? So you grew up in New York, and when did you start experimenting with drugs, and then when did it become a problem?
I started experimenting a little late. I remember drinking in college, keggers and the like, and getting quite drunk and sick regularly. And I remember going into a dorm room, and people were smoking marijuana out of a little water pipe.
Yeah.
The sound, I can sort of remember the sound in my visual cortex, that
Right. Yeah.
which are now backs. And I walked in the room and I said, oh, no, drugs are not for me. And within about a half an hour, everybody was laughing and having fun and, falling down on the floor. And I was like, let me have some of that. And, I started smoking marijuana pretty regularly after that. And that turned out to be my drug of choice, cannabis. Throughout all the years of my active using, alcohol was important. I found cocaine and other stimulants. They were lovely. Not so much opioids as it turned out, but marijuana was, it was the hardest drug for me to give up. And bearing in mind that the marijuana of my day I got sober in 1984. So in those days, it was about 1/10 of the potency that the marijuana is nowadays that people are getting exposed to. So I worry about marijuana as a drug a lot, for particularly our youth. But that was the one that got me and held me throughout my medical school training days and the early part of my career.
Okay, so you started smoking marijuana. You were in college, right? And you were approximately what, 20, 21, 22, something like that?
Yeah. Actually, I went to college when I was 18. So that those first 3 years, I got pretty entrenched in regular marijuana smoking.
Okay. But you were still able to get good grades because obviously you got accepted to medical school, and you went to medical school.
I did. Tongue in cheek, I say I must have been pretty smart to manage, being stoned all the time and getting decent grades.
Right.
I was never on the verge of flunking, or my performance certainly was impaired, unquestionably. And God knows what people thought about me, but that was the life I lived. And when I was in my residency, I would smoke, between call and. Had very little respect for the clarity of mind that I could have had without it.
Right. Did other people know that you were smoking weed?
I was with a partner at the time. He knew. He thought I smoked too much, but wasn't really that concerned about it. I don't think, I'm not aware that anybody in the hospital system or the medical school system or my residency program ever was aware. If they were, they never told me. And I have friends 30 plus years later who I talk about, when I would be off call at night, but sleeping in the hospital, smoking marijuana, sticking a towel under the door. And they were out working on the floor because I was much more efficient. There was a woman friend of mine, and she had no idea at all.
Wow. Okay.
Yeah.
And then when did you realize it was a problem?
Well, you know how it is with those of us that have addictions. There's a little voice in our head that periodically speaks up. Usually it's a whisper and it's an annoyance. Shut up. It was not okay to smoke dope and be a doctor, but that's what I was doing. But it was not until I moved to Las Vegas, and I just coincidentally, the guy I went to work for as a family doctor was running a treatment program. And he said, you're going to cover for me on weekends when I'm off. So we're going to teach you about alcoholism and addiction. So I got, it was actually, you might know of them, Raleigh Hills hospitals. Back in the 80s, they were an aversion treatment program. We would take people in, we give them a drug, Emetine, and make them puke in response to drinking alcohol. So it was a very odd treatment. Schick Shadles is sort of the model that Raleigh Hills was based on.
Okay.
But as a result of being associated with that, I got exposed to some amazing mentors in the addiction field. One-on-one or small little group sessions that they had arranged to train their medical team. So I was trained by Mark Shuckett, who's the sort of father of genetics and addiction, and Charles Lieber, who's the guy who discovered that alcohol affects the liver, Mendelsohn and Mello, who were sort of the psychiatric mavens way back. I mean, this is, again, the late 70s, early 80s. So I learned a lot about addiction, and every once in a while, somebody would just be describing blackouts. And that little voice in my head would say, well, you do that. You can't remember what you did the night before. And it's like, shut up. Up.
Now, are your blackouts from smoking cannabis or from alcohol?
No, from alcohol.
From alcohol. Okay,
yeah,
so you were drinking and you were smoking. So you were smoking cannabis on a daily basis, I would imagine.
Yes.
Daily.
Never a daily drinker. Never classically addicted to alcohol. I never had DTs or really any significant withdrawal that I can remember. But when I stopped smoking marijuana, I had withdrawal. I had anxiety and sleep problems and stuff. Yeah.
This reminds me. I had a friend of mine. This was after I graduated from college. He was a dentist, and he liked to do cocaine. And I remember going to see him at his dental office, and I remember him having cocaine in his nose. I was like, "Hey, dude, you got cocaine in your nose. You're gonna have to clean that up." I mean, it's just so crazy the things that people do, and if you're actively kind of in it, then you're much more aware. And even now, right now that being through it, I'm sure can see. You can see it. You can see other professionals. You can see other professionals, period, that are active in their drinking and their drug use.
And we treat a lot of health professionals, physicians and the like at Las Vegas Recovery Center, primarily with chronic pain problems. And there's always a story, and it's a convoluted, well, I took the medicine, but it was a bad night and it was snowing and I had this terrible pain condition. I didn't think I was going to have to work, but because of the snowstorm, I got called in. And so that's why I was intoxicated at work, Right. I mean, it's just justification, rationalization to try and make sense out of this crazy disease that drives us to do things that are very unhealthy for ourselves and for others, and to be able to really discern that that's what's going on. Denial, classic denial.
Yeah, and this is I'm really glad that we're talking about this, because not everybody is a low bottom drunk. There's a lot of people that are like yourself, medical professionals, dental professionals, like business executives. There are a lot of people that are not low bottom drunks, and they're, on the outside, from all appearances, they look like they're successful, and you never would know that they're empty inside. And so what?
Well, I was just going to say, the data suggests that profession is the last to go. So, family and relationships goes, self-care might go, self-esteem certainly, the psychiatric complications, but somehow or other, high-level professionals who are really, earning a living and very, very attached to earning that living, lawyers, for example. The last thing to go is the professional, I won't say professional integrity, but the ability to earn a living and stay employed. And that was the case for me.
Well, yeah, it's like they started drinking and using while at the same time going to school, or maybe not, maybe it was after that. But regardless, to your point, they had to do whatever they needed to do to continue earning a living financially. And if they're earning a living financially, they can justify why, hey, I'm not causing any problem. I mean, even though my wife is going to leave me, my kids hate me, I don't have any friends, it's okay because I'm still earning a living and I'm still respected by my colleagues.
Sure. And that was part of it for me. I mean, I was on the verge of disaster. I drove drunk all the time. I always had drugs. I always had a roach in the car. I actually checked to see with the kids, do you still call it a roach? That little end of the joint. Some do, some laugh at me, and say, oh, old man,
Right. They're like,
it's in a pen. And But anyway, it just hadn't happened yet, so my story was not yet, but all of it. I mean, if I had gotten a DUI, I'm pretty sure that the treatment center that I was working for at the time wouldn't have continued to employ me as their medical director. Just saying.
Right.
You know,
Right.
My relationship was teetering. So it was all kind of there. And I just chose to get sober, on a very unassuming Saturday morning. It was just like, I can't do this anymore. I just can't. That was my bottom, was I just can't do this anymore. And that was the beginning of my rocky road to recovery.
What was it? What was it that made you think I just can't do this anymore?
One more time I found myself stoned when I vowed I wasn't going to smoke dope, on call, confused when I was answering a call for the emergency room. And I just looked at my partner and I said, look, I just can't keep doing this. And he's like, well, yeah, give up the weed, but, you can drink. And, it was like he wasn't on board for this plan, but it didn't matter. It was, job or no job, relationship or no relationship. I was at a point where I couldn't, in my own internal process, continue to live the way I was living. Okay.
So what did you do?
It's funny. I had been going to AA as a guest to learn about AA. I heard Father Martin. Some of your listeners, I'm sure, are familiar with an old priest who created Chalk Talk, and Father Martin's Ashley across the country. But anyway, he spoke at a conference, and he said, you don't have to be alcoholic to treat alcoholics, but you have to know Alcoholics Anonymous. So I started going to Alcoholics Anonymous meetings to find out about AA so I could be a better doctor.
Okay.
And of course, I'd hear things that related to me on a regular basis. And
you're like, wait a second.
Yeah. Monday morning, I'd hear some stories and I'd think to myself, oh, I should just raise my hand and get this over with, as an alcoholic. But it took what it took. I probably went to those meetings for over a year. But I knew about meetings and I knew about recovery, and I had a lot of knowledge about the disease of addiction. And I called a friend of mine who was a woman physician in recovery, a couple, 3 years sober. And I said, Maureen, I'm not drinking anymore. I got sober. And she's like, oh, that's great, Mel. Where are you going to meetings? And I said, oh, I can't go to meetings. I'm the medical director of a treatment center. And she said, oh, how you doing? And I said, oh, I'm terrible. I'm depressed. I'm anxious. I can't sleep. My stomach hurts all the time. I'm a little suicidal. She's like, oh, good. Oh, good. When you feel better, when you want to feel better, give me a call and we'll go to a meeting together. And it's like, I had some choice words for her. She dropped off the Hazelton 24-hour book at my doorstep.
Oh, wow.
Yeah, I still have that book.
There you go.
And a couple of days later, I called her and said, I give. I couldn't survive the way life was going because it was too painful without the anesthetic. And, the anesthetic was the drugs.
Right. The drugs were the solution, and now the solution on. So what are you going to do?
Yeah. The proverbial question for every alcoholic and addict is, how do I live without? I know I can't live with, but I have no idea how to live without. And for me, it was all about AA. I did not go to treatment, to a treatment center. I continued in my job as director of the treatment center throughout all this, but I started going to meetings in earnest. And, they told me to start listening to the similarities, not the differences. And when I started doing that, my life started to change, a little bit at a time. And I learned that there were solutions to problems I didn't even know I had, So
did the treatment center? When did the treatment center find out that you got sober? You just didn't talk about it.
I didn't talk about it.
Wasn't an issue. Didn't talk about it. Okay.
No, and I was never diagnosed with alcoholism, so I never made the declaration to the medical board even that I had alcoholism, because nobody ever told me I had alcoholism. I figured out that I was in trouble. And so, it was splitting hairs, and I worked through that with my sponsor. And, it was a number of years into it that I realized I just was, I was working a solid, healthy program, thank God, and, was committed to my sobriety and was going to stay sober, It was going to stick, because the first little bit, who knows if you're really going to do it,
Right. And then when did you realize this is where I want to stay? I mean, I know, like, for me, I got sober, and I wasn't really planning on staying sober. I was just like, okay, I'm gonna get sober for a little bit, and I'm gonna see how this goes. But I wasn't planning on staying sober. So what about you? Did you plan on staying sober, or did you when did that happen? I mean, for me, my life just continued to get better. I mean, not that it was perfect, because I still had all kinds of stuff that happened.
Yeah.
But I made the decision that this was the life that I wanted to live, and this is the path that I was going to go down. How long did it take for you to make that decision?
I honestly think, Tim, that I worked up to the decision for the entire period before this day, in time when I said this is it, and I made that decision that day. This is the way I want to spend the rest of my life. Now, I didn't have a clue as to how to do it. I didn't understand, how am I going to stay sober New Year's Eve? I got sober October 13th, so how am I going to stay sober during
holidays?
Christmas?
Are you kidding me?
Yeah. And my sponsor at the time said, "Is it Christmas today?" No, it's Thursday so I don't have to be sober on Christmas today. And I learned the principles that many of us who've gotten and stayed sober for a long period of time have internalized, which is there's a better way, and I love being sober. It not quickly, I mean, with the first 3 to 4 months, I wasn't so happy. I wasn't joyous. I certainly wasn't happy, joyous, and free. But I got glimpses from what I heard and saw in other people, and they held my attention. And I was so well educated about addiction that I understood the concept of brain disease, and there's no going back really successfully, and all that stuff was sort of ingrained in my knowledge base, and I think that supported my staying sober.
Yeah, I know I was the same in that I looked at all these other people. It's like they're so happy. I mean, the first meeting I ever went to, it's like they're so happy. Why are these people so happy?
Yeah,
this is the fate worse than death. And then you're around them long enough, and then things start to change. And through the learning how to be honest and outward focused and of service, and in a community with other people that wanted to be clean and sober and live a happy and healthy life, things start to change, right? Yeah.
I mean, it's when I came into the rooms, I got sober at a men's stag in Las Vegas, rough and tumble, half the room had been in jail or prison, and it was serious AA. And, they'd say, if you want what we have, and, I drive up in an Audi, I had a nice watch, I had a relationship, a beautiful home and medical practice. And I'd look around at waiters and carpet layers, and, I'd say, not really, I don't want what you have,
Right.
But the truth of the matter was that same guy or those same guys had this level of comfortability in their life, the fun that you're talking about, the fact that they were off laughing and being spontaneous, which was something that I didn't have any clue about. And those were the things that attracted me and held my attention. And, those are the things I wanted and, still want today,
Was it hard to find the similarities? I mean, you drive up, you said you're in a good place, you have a nice watch, you have nice clothes, you own a medical practice. I mean, I've heard your story lots of times, and it's hard, and for it's harder. If you're looking for the differences, they're easy to find.
Yeah, and
they're easy to find too.
It depends which lens you look through, right?
Right.
When I got, the turning point for me was I was at a dinner party. I was sober 30 days, and they were serving wine, no problem. People were smoking weed, not so good, but no problem. And then at the end of dinner, there was a liqueur being served. And I looked at it, and I never had any interest in that sort of a drink. It was just not my repertoire. And I looked at it and I said, that looks really good. And I thought, oh God, I got a worse case of this than I thought.
Yeah,
because
right.
it was It reminded me of the story in the AA Big Book about, Bill thinking that he could put scotch in milk and everything would be okay. So the next day I went to an AA meeting and I started listening differently. And, my life began to change. Yeah.
Okay, cool. Okay. So now let's kind of switch gears. And now you're chronic pain and addiction. That's kind of your niche. That's your specialty. How did you end up? What led you to that?
Fortuitous God. I developed a chronic pain problem with my back, and in my pursuit of dealing with it, going to doctors and having epidurals and radio frequency ablations and MRI scans and physical therapy and chiropractic, this kind of chiropractic, and I just became very frustrated because my back pain is about the same today as it was back then. And I got real interested in, about the same time, opioids were really on the rise. By 2000, there was a serious opioid epidemic, though it wasn't publicized. Most of the people, more than 50% of patients who I was admitting, were addicted to opioids and were detoxing from opioids. And at least half of those people, when they were done detoxing, would say to me, "What are you going to do about my pain? I'm on opioids because I'm in pain." And I would say, "I don't know. I'm not a pain doctor.
Right.
Go back to your pain doctor." Well, that's the person who was prescribing the drugs. So we sat around a table, and I came up with an idea. It wasn't really original, but my drive was, let's take care of people who have co-occurring pain and substance issues and see what we can do. And, we put together the Las Vegas Recovery Center's chronic pain recovery program. We chose to call it pain recovery instead of pain management, because pain management really seemed to refer to medicating and procedure-based, and created this robust biopsychosocial spiritual program for people who have chronic pain. And it's been running now for 13 years, and I'm proud of it.
Yeah. What's the difference between acute and chronic pain?
That's how we miss the boat. Acute pain is related to injury. It's functional. It's purposeful. It's feel pain so that you spare the damaged tissue until it heals.
Right.
So it's the alarm clock part of the pain system. It's what pain is circuited for. The mistake we made is that chronic pain just means the same process that goes on and on and on. So instead of just lasting a little while and healing, the tissue, for whatever reason, doesn't heal, and we have this pain that continues. And that's just simply not true. But as a result of believing that, we try and diagnose and treat chronic pain the same way we diagnose and treat acute pain. We do scans, we do CAT scans and myelograms and discograms to define what the source of the back pain is, and then we go after it with injections or we throw a blanket of drugs like opioids on the system to suppress the pain overall. Or lastly, we end up in the surgeon's office who says, "You've got an unstable spine, you've got a bulging disc. I'll cut that out. I'll fuse your spine, put rods in your spine so you can't bend and press on the nerve, and you'll be good to go." And less than 20% of people respond positively to that treatment. Less than 20% of people have improvement in chronic pain, the chronic back pain, with back surgery. So we got to come up with a different plan. Opioids aren't a good solution. Surgery and this whole medical system isn't a good solution. And it turns out the reason it's not a good solution is that chronic pain is a different process. Acute pain is the alarm clock. Chronic pain is like the alarm clock went off and it's just buzzing away, but it's not functional. It's not purposeful. I have this back pain from a bulging disc, and it just bugs the hell out of me, and it frustrates me, and it makes me angry, and sometimes it makes me depressed, and sometimes it keeps me from sleeping. But it's not because I can't walk or I can't stand up or I can't do exercise. I can do all that stuff. So it's a maladaptive function, and it happens not in the tissue, but in the central nervous system, in the brain. Mm-hmm. So if we're going after the tissue and ignoring the brain, we've missed the boat. what's happening in the brain. I have a lot of thoughts about my pain, and I have a lot of feelings about my pain. And until and unless I deal with thoughts and feelings, never going to get better. And that's the fundamental basis of our program.
Okay. Yeah, I mean, so acute pain, that's a trigger because you really do have an injury, but that's short term, right? And then you've got the chronic pain, which, if I'm hearing you correctly, a lot of it, it's basically it's in your mind, right?
I'm laughing because I had a discussion with a patient, and we had this very discussion, and I explained this to her, and she said to me, "Are you telling me my pain is in my head?" And I said, "Well, Tiffany, you have headaches, chronic headaches. So where else is your pain? Of course it's in your head, but the implication that it's in the mind or in the head or even in the brain somehow disconnects it from the validity and reality that it's real pain." So I have 5 key principles that we go by in treatment. And the first one is that all pain is real. So I'm not here to debate that you have a real experience of pain. And then, but the second key principle is that thoughts and feelings are the genesis of that pain. And that's where you have to spend your time and energy if you want to get better. And sometimes I lose patients because they say, no, the pain's in my back. I mean, I feel that way. I don't have pain up here. I have pain down here. But I understand that the circuitry of the nervous system is such that when I have a signal going up my spine into my limbic system, which is where we feel emotion and pain, if I continue to bombard that system with a signal, the system will change. We have a plastic brain, a neuroplasticity, the basis of growth and development, but also the basis of many diseases. So now I have a process of sort of this reverberating circuit, almost like a memory of the experience. And that's what's driving my distress, my suffering. And that's all modifiable. I just had a conversation with a patient over at the center who's getting ready to go home. And this guy has terrible back disease. I mean, if you looked at his spine, you'd cringe. And he came in saying, I am on the verge of being crippled by my spinal disease. And I challenged his, can you walk? Oh, yeah, I can walk. Have you ever not been able to walk? No. If it hurts, I might want to lie in bed. So how are you on the verge of being crippled? What does that statement mean? Or he said to me one day in group, he said, my feet are on fire. I said, oh, should we get the fire extinguisher out? I've never seen your feet burst into flames.
Right.
So we begin the process of irreverently challenging the thoughts, the cognitive distortions about pain, because that's a big part of the balance of how I think, because what happens is I feel a sensation and then the rest of it happens up in my mind, my thoughts and feelings, and it's really all fear-based, not terribly different than addiction is fear-based. So if we can uncouple the fear from the behavior and really sort of look at, well, what am I afraid of? I'm afraid I'm going to be crippled. Are you crippled now? No, I'm not crippled now. Are you likely to be crippled next week? No, not really. There's nothing. It's just, I have this image that my spine is going to cause me to be crippled, but it isn't true. And when you begin to challenge those false narratives, then the story, it sort of opens up and the person is able to open up into the possibility that life could be very different than it's been.
Right. So would you say it's just like they say, what do they say? Thoughts become words become actions become things. And it's almost like whatever you believe about yourself, whether it's good or bad, it's true. Like whatever you believe about yourself, you're right.
Yeah, that's the fifth key principle in chronic pain treatment, is that expectations influence outcome. So what you believe is going to happen, what you believe about yourself is more likely to happen because you believe it happens. Right. Why is that? Because our minds are extraordinarily powerful. They create this image, and the image cripples us. When actually the truth of the matter is I have a stenosis in my spinal column and it presses on the nerve. And sometimes it really is a strong sensation. That's the truth. The rest of it is all, the story heaped on the story. And pessimists have a more realistic view of what's happening, but optimists do better. They're more successful.
It's almost
so
like
we encourage.
It's like the placebo effect, right?
Well, the placebo effect is.
I mean,
No,
it's like
absolutely.
That's why placebo works, because if they believe that they're taking something, then it's gonna work. Or
do you know that placebos work almost as well as opioids for chronic pain?
There you have
statistically, opioids work in maybe 30% of the time. If I give you a sugar pill and say it's going to work, 25% of people are going to have less pain. I mean, what the hell? Why wouldn't I do that?
Yeah, that's it.
So we don't use placebo medications, but we do use the impact of the positivity to impact a patient and optimism. And I mean, I can't tell you how much cheerleading I do in the process of an interview with a new patient.
Right. Well, and it's almost like you as the doctor, and if you can get the patient to buy in, like, hey, no, this is going to work. Like, this is what you need to do. You need to do breath work. You need to take ice baths. You need to go do red light therapy, which I believe in those modalities anyway.
Apparently.
but if you're getting them to buy in, if you're the cheerleader, so probably how much of your job is being a cheerleader?
I think a substantial part of any physician, any good physician, is part cheerleader, and significant part cheerleader. Believing in the patient's ability to heal him or herself, believing in the patient's power in the process, and not, you got this, here's what you need, see you in a month,
right?
Which is that's kind of the way our medical system works, and it's a disservice to the well-being of a patient, to the integrity of a patient. So I think that cheerleading, and not in a pejorative way, but in a, I believe in you.
Yeah.
And imparting that information in a positive, optimistic way is very important. And I can base my belief in science. I mean, I can say, look, here's what I know about your brain. I can show them slides of a brain with chronic pain that changes entirely, and that is almost atrophied in the areas of healthy emotions. And just as an aside, Tim, for the addiction folks who are listening, the area of the brain that lights up in an MRI of somebody with chronic pain is the same area that lights up when people take a drug. Nucleus accumbens, ventral tegmental area, reward center. So just like there's a circuit of addiction, there is a circuit of chronic pain that's reverberates inside the human brain, and the treatment is uncoupling the stimulus from the response. In the case of addiction, it's take the drug out of the system and allow the system to heal. In the case of chronic pain, it's challenge the beliefs about chronic pain and the emotions that result, and uncouple them so that the person has some latitude and freedom to move around in their body.
Right. So you say that opioids are usually not the right treatment for chronic pain. Tell me about that.
Yeah. Well, opioids, I used to sugarcoat this, but the truth of the matter is that opioids in chronic studies of people with chronic pain who used opioids, they helped mild to moderately in less than 20% of the patients who took them. So that's what the data shows. And that was a very large double-blind study. So what does that actually mean? And how do we sort of tease out the facts? Well, opioids, if anybody in the world takes an opioid, it's like putting a blanket on the brain, and it takes the pain levels down, it calms, it relaxes. For some people, it gives a little energy buzz, as you know, from the, call it an abnormal circuitry. Some people take hydrocodone and they're jazzed up, they're energized. Yeah. And those are the people that get addicted. But for my patients, they take an opioid and it works. The problem with opioids is, like any mood altering drug, it works for a period of time and then it stops working because it's got a time limit on it, a half-life. So What happens next? I simply repeat the dose. So I go from feeling bad, take the drug, feeling better, drug wears off, feeling bad, take the drug again. And as we do this cycle, several things happen, as you well know. One is tolerance. The drug stops working. So the only thing I can do to make the drug work is to boost the dose. So if I've taken one 5 milligram hydrocodone then I have to go to 10 milligrams of hydrocodone. And after that stops working, I need to go from hydrocodone to oxycodone because it's stronger, and maybe then on to morphine. So because of tolerance, I'm in more pain because the drug isn't working as well. Equally important is that if I take hydrocodone or oxycodone or morphine regularly, at some point, and some point pretty quickly, within the next 10 to 20 days, I'm not going to be able to be without it without some discomfort, and that's withdrawal. So physical dependence to opioids develops in most systems within the first month for sure. People who are on opioids at 30 days are 20% likely that they're going to be on them at 3 years. So there's a significant reason to keep doing it. But if I take the drug here and I take the drug here, the withdrawal is going to occur between doses. So at 3 hours, my pain level is going to bump up. And what am I going to do then? I'm either going to take an extra dose, or I'm going to struggle with pain for 2 or 3 hours and hold off and then take the dose at the 5th or 6th hour. That's an inevitable outcome for most people who take opioids. So we've already got a terrible situation. Right. Add the third thing to this, which is called opiate-induced hyperalgesia. We're pretty clear from the literature and the studies, both in animals and in humans, that if I take an opioid on a chronic basis, the best it's going to be is somewhere around 40 milligrams of morphine equivalent per day. If I continue to raise the dose because I'm tolerant or physically dependent, then my pain level is going to go up as a result of being on opioids. Opioids cause inflammation in certain parts of the brain. They cause an elevation of certain inflammatory neurotransmitters that cause more pain. So opioids cause pain in the long run. It's counterintuitive, but it's true.
Right.
And, some patients I tell this to, they roll their eyes and they say, you're full of crap and that's crazy. It doesn't make any sense. A lot of patients say, I feel like that's true. If I look back 5 years from now when I started, I'm in way more pain now than I was when I started.
Right.
So something must be happening. So, not starting is the solution to ending up in this nasty spiral of downward efficacy. And what we have now is, the CDC has told us opioids are not the best treatment for chronic pain. Doctors have gotten on board and they're withholding or they're cutting people off almost irrationally. And we've got a couple million people who are opioid orphans. They're on these high dose opioids and the doctor says, you got a month to come off them and then, I'm not giving them to you anymore. Right. And, that's one of the reasons we're in this heroin epidemic and, heroin plus fentanyl epidemic, and overdoses are actually, unfortunately, on the rise, especially with COVID and, all the reasons that COVID has made life hard for people.
Right. And we're going to get to COVID in a second. I'd like to talk about that just because it's such a big deal right now.
Sure.
So I'm just sitting here thinking about pain. So you've got pain management doctors, and so a pain management doc is going to prescribe opiates for a long period of time. Is that accurate?
Yes. No end in sight.
Okay.
And when I teach those doctors, I teach about, let's have an exit strategy for any kind of treatment plan.
Right.
If you're going to start, how are you going to stop? And there's that is not something that's part of their armamentarium.
Right. And is it well known? Like, do they know that opiates don't continue working after a certain period of time? Is that common knowledge amongst doctors? Pain management doctors?
Yeah, I honestly don't know if there's any studies on that. Like, doctor, if you knew this, how could you keep doing this? Because that's the obvious question. I frankly think it's more like, gee, it seemed to work for a while. I don't have much else. Everybody looks like a nail if all I have is a hammer. So I'm just going to keep hammering, and you'll keep coming in, and you'll keep, taking your prescription, and I'll raise the dose every once in a while, and we'll try and help you have a better life. When, if they really spend time talking to the patient, they would understand that the patient's life is shrunk, that they're in bed more of the time, that they're in pain more of the time, that their relationships have suffered as a result of the chronic use of this medication, that their thinking has suffered, that they feel bad about themselves, that they feel like they're addicted. All those things are happening. And I don't think that most prescribers realize that. And even if they realize it, they have not a clue as to what to do about it.
Right.
Unfortunately.
Yeah, I mean, I guess my question is like, is it ethical to continue prescribing? And because then you have, so it's like you're trying to help and you think you're helping. However, if you really look at it, and who knows if they're even spending enough time with the patients to know what's going on in their life, what's happening in their life, how are they feeling spiritually, physically, and emotionally, right? I mean, it's just a much deeper question than a pain management doctor is going to have time for.
In a 10 or 15 minute visit. Yeah, you're absolutely right. It takes 10 minutes to say yes and write a prescription. It takes 45 minutes to say no and have a patient walk out angry because you're not going to give them what they think they need, what they want. So there's a lot of forces that push against, let's say, doing the right thing or even opening the discussion. And when I counsel docs about their practice, I don't mean to, I try not to bash their activities. They're swamped. They're so busy, and they really didn't come into pain management with the skill set that they need. Most of the pain docs in our country trained in anesthesiology. Well, anesthesiologists are trained to put people to sleep. They don't talk to patients. And now here they are in an office with these very difficult, we call them heart sink patients. These are patients, I see that this person's on the schedule and my heart sinks. And they have 30 or 40 or 50 a day. So they're in a tough bind. They don't really have the skill set. They don't have the time. They don't have the energy. And, what else are they going to do? So some of them get real rigid and say, we're not going to prescribe anymore. I'll just give you injections. But some of them just keep doing what they're doing because that's what's in front of them. And, I don't know if I'd label it unethical, but I wish they would do something different. Right.
Well, it's the path of least resistance. Yeah. It's easier, right? And it is a Band-Aid, and it's going to keep them from going out and seeking and on the streets for a short period of time.
Theoretically, yeah. I mean, most heroin addicts started with prescription opioids, although I will say that our pain folks, the people who take their opioids for pain, are not in high levels going out and using heroin. The heroin really is that group of addicts who started with pain pills, kids stealing them out of their parents' medicine cabinet, got hooked, and then it got harder to get the pills, so now they're moving to heroin. So it's not the 40 and 50 and 60-year-old pain patient, but rather the younger person who has a substance use disorder, and they're just manifesting it in different ways. But certainly making it harder for doctors to prescribe opioids without the other part of the story leaves patients high and dry, typically.
Right. So what are the most important elements of a treatment plan for patients with chronic pain and addiction?
Well, we'll start with the most obvious, which is physical, although it doesn't need to be first. But it's going to be physical, cognitive, emotional, and spiritual. So the physical elements are related primarily to getting the person moving. Motion is lotion. People become kinesiophobic. I'm afraid to move because it hurts, so I don't move. And the key to that is, even though it hurts, it's not going to harm you. Hurt versus harm. So get moving. So we at LVRC have a physical trainer, and they go to physical therapy on a regular basis to do stretching and mobilization exercises. And then people who have different conditions might do strengthening and other kind of physical therapy interventions. The other physical things that have some efficacy in our hands is massage therapy, both loosening up tight stricture in the musculature, but also the effect of touch on patients, especially nowadays with COVID, is very important. We have an acupuncturist who treats people once a week. Some people resonate with that treatment, other people don't. We do yoga 4 times a week. We do qigong once a week. So it's all about mind, body, movement, breath, as you said, getting the circulation going, getting the breath into tissues that have been immobilized, because typically people are immobilized when they're in pain. So that's the physical part of the program. The psychological or cognitive part we touched on, but it's really looking at people's feelings. CBT, cognitive behavioral therapy, has some good database in efficacy for chronic pain. Dialectical behavioral therapy, DBT, particularly around distress reduction, is efficacious. And then acceptance commitment therapy or ACT. Stephen Hayes from Reno wrote a book about ACT with chronic pain, and there's quite a good literature base. And it's basically about finding what's valuable to you, and if you function towards value and you commit to that function, the pain becomes less important. That's what's happened with this fellow that I described. His pain scores really changed as much as they might have, but his quality of life and his engagement in his life and his enthusiasm to get back to doing the things in his life that he let go because of his chronic pain is exciting. The third part is the emotions, and we've talked about that, but it's really the distress reduction techniques are key. People are anxious, they're fearful. Sorry. I'm going to decline this call. Sorry. It's my niece, but she doesn't get me right now.
No problem.
I'll send her to Facebook. Sorry. So the emotional system is on hyperdrive, and there's a whole bunch of stuff that I'm exploring right now with the polyvagal theory and the activation of the nervous system in response to stress and fear, and really providing a safe environment for people's nervous system to gear down, and then having the opportunity to be in group with other people and co-regulate their anxiety is sort of a very valid pain relieving strategy. And then the fourth is spiritual, and we are strong believers in 12 steps, and we get people to as many meetings as we can during these COVID times. Chronic Pain Anonymous is actually started in Phoenix. It's a 12-step based methodology that we introduce people to, but really it's AA and NA that are the foundations for people's 12-step support system, if they're able to engage. And then the final part of the spiritual program is mindfulness practice, a big part of our distress reduction methodology, but also just sort of being present in the moment without judgment is all powerful. And each one of these techniques that I've described is based in pretty strict, staunch data evidence.
Yeah, that sounds like a very comprehensive approach.
It is, and it's not
plan.
Yeah, not easy to deliver. It's costly, and it takes a lot of personnel and a lot of skill. And we've developed all that over the 10 to 12 years that we've been in operation with our chronic pain program. But it's not a run-of-the-mill patient. Putting a patient like this in a group and saying, we don't want to hear about your pain, we want to hear about your drugs, because that's really the issue, is missing the boat too for
right.
Our field. It's a co-occurring process, and if I ignore the pain, then I'm never going to get the person's addiction under control, more than likely.
Yeah, there's so much more to it. It's more than just the pain. It's more than the drinking. It's more than the drugs. It's got to be all of it, right? It's emotional, spiritual, physical. And you mentioned breath work. What's your? And I'm doing
Wim Hof. I can tell.
What was that?
Are you doing Wim Hof?
Oh yeah. I've got the Wim Hof. There's a place by me called Optimize, which shout out to Optimize. It's they have ice baths, they have infrared saunas, they have red light therapy. They have Wim Hof workshops. Both Michael Ravello and Jesse Meringue, they're both Wim Hof certified. And so I do breath work every morning. That's the first thing I do. And I actually just read a book called What Doesn't Kill Us by Scott Carney. And this is a journalist that set out to debunk Wim Hof. And so he was like, that was his mission, was to debunk Wim Hof. And on that journey, so he had to go through Wim Hof's training conferences, and he just became a huge believer and a huge advocate. And he talks about, Laird Hamilton has his XPT training. There's so much around breath work. And I know, like, for me, the very first thing I do in the morning is breath work. And what that does is that fills my body up with oxygen. It increases my adrenaline. It gets me going. That's the first thing I do before I get out of bed. And I'll tell you what, I am up.
Yes. Got it. I've explored it personally. We haven't instituted it in the treatment center because we're Joint Commission approved, and we have only so many hours in the day to do so many things. And for somebody to really explore that kind of activity is not within the purview of our treatment program. But it intrigues me, certainly.
There's a great book I just read. It's called Breathe by James Nestor. The New Science of a Lost Art. I don't know if you can see that.
Yep.
That's an amazing book right there. That's an amazing book. So
after they buy my book, then they should buy that book.
Absolutely. It's all part of it. It's all part of it. Yeah. So, okay, now let's talk. I know we've got a few more minutes here. Let's talk about the COVID-19 environment and what kind of an impact have you seen on your population?
Well, we've seen people somewhat reluctant to come to treatment. And actually, at the beginning of the epidemic, we were busier than we are now for whatever reason. You never know why people come to treatment. But I think that people are frustrated and challenged by the world environment and the personal environment, the restrictions. A lot of people are unemployed and losing their insurance, so they don't have the ability to access treatment. I think that the ability to connect. So I'm seeing a lot of relapse. I mean, we have a fair number of people who are coming back through because they were doing okay when meetings were up and around and live. And now that the meetings are pretty much shut down, I mean, Vegas is sort of 20% of meetings are up and functioning, but most are still on Zoom or not happening. And as a result, people's support system, that co-regulation system that they've become known to them has really become fragmented. So we've tried to maintain our alumni association and our outpatient services for folks like that. And some are accessing them and some unfortunately aren't. And no end in sight. So I worry for our recovery community in general. I hear stories all the time. I imagine you do too, of people who've been sober a while or a long time and who are relapsing in the face of the pandemic. And the skills that we teach that we've been talking about in the pain program really are skills that we also teach in the addiction recovery program. And that, it's kind of what we learn in AA, how to reduce the distress in our nervous system so that we're better able to be calm. And, whether it's your breath work or meditation, mindfulness practice, or yoga breath, or, there's just so many ways to down-regulate the nervous system. But unless we do that, then we're on a heightened state, and that really puts us at risk for a whole lot of other things. And interestingly enough, I've been studying cytokines. Cytokines, you might have heard of them because there's a cytokine storm that's associated with people who get really sick with COVID. And cytokines are inflammatory neurotransmitters. Well, when we are anxious, cytokines are secreted in our nervous system, and they cause pain. So being anxious causes pain, and being less anxious diminishes pain. So any non-pharmaceutical method for reducing anxiety is fully supported by me and our treatment program.
Well, that makes sense. It's like anxiety. I would imagine that there's inflammation somewhere, and with the inflammation comes pain. That's it.
That's the simple formula. And cytokines appear to be the vehicle for that.
Okay. So what do you want to let the audience? How can the audience find out more about you? Which books should they read? You've written several books. Which is the most recent? And how can people find out more about you? And how can people find out more about Las Vegas Recovery Center?
So the Pain Antidote is the most recent book. A Day Without Pain is sort of the first and then revised version of the book that I kind of like the best, my sort of heart favorite. Las Vegas Recovery Center, you can access the website at lasvegasrecovery.com. And I'm just looking for the 800 number because I never call it. I'm going to give you the regular number. It's 702-515-1374. That's the admissions office. They're always available to answer questions. The message for folks who have chronic pain and are taking opioids is life can be a whole lot better than you could possibly imagine. Much like I say to any person who's suffering from addiction, better than your wildest dreams, as it turns out. And you have to take some steps, eventually take the leap into giving up the opioids, and don't do that spontaneously. Get help with it with a physician or a detoxification center so that you're safe and medically supervised. But the net result of coming off opioids is a better life. And then there's all the life-enhancing measures that we've been talking about for the last hour.
Yeah. Awesome. Thanks again so much, Dr. Pohl. Really, really great getting to know you and getting to learn more about more about your program and pain management. I really got a lot out of today. Thank you so much.
Great. Thank you. My pleasure, Tim.